Moving on to the next heading, we have finished the introduction to the classification, mechanism of action, actions. Next is pharmacokinetic highlights. That is not that important for calcium channel blockers. You can refer that in your textbook. Moving on, the next heading after pharmacokinetics is ADRs. Again, for calcium channel blockers, you can classify the ADRs into cardiac ADRs and non-cardiac ADRs or extracardiac ADRs. Now, cardiovascular ADRs, the way in which you classified the cardiovascular actions of calcium channel blockers into verapamil like or and the DHP like, that is the DHP non-DHP ones. Same way you can classify the ADRs also into cardiac depression, that is verapamil types, and vascular, that is vasodilatation, that is the DHP like effect. This again is very, very important. Try to follow me carefully here. So, if there is excess cardiac depression, what is going to happen? What adverse effect can you anticipate? If there is excess cardiac depression, it is going to be bradycardia, heart block, and worsening of heart failure. Because if the patient is already having heart failure, that is going to be worsened. If the patient is having heart block, that is going to be accentuated. Worsening of heart block. There is bradycardia, and the bradycardia I have written as direct bradycardia, because this effect is because of a direct action of the calcium channel blocker on the heart, on the myocardium. Because these, that is verapamil and diltiazem, both of these can produce direct bradycardia, you should be very careful. You should not combine them with beta blockers, because beta blockers also produce bradycardia heart block, and they act by a different mechanism. If you combine beta blockers with verapamil or diltiazem, what is going to happen? Both of these will produce supraadditive heart block, supraadditive cardiac depression that can be very dangerous for the patient. So remember, you should not combine verapamil diltiazem with beta blocker. You should not combine non-DHPs with beta blockers. Next, verapamil diltiazem should be avoided during heart failure, because they can worsen the heart failure, and LV dysfunction, because they can worsen the cardiac depression. So these are very important, and all these are seen more often with verapamil diltiazem than with dihydropyridines, and this is because of excessive cardiac depression. This is one group of ADR. Second group of ADRs are because of excessive vasodilatation. These are more often seen with dihydropyridines, nifedipine and other dipines. The most important ADR here is they will produce reflex tachycardia. How do they produce reflex tachycardia? Because they produce vasodilatation, right? Because of the vasodilatation, there is going to be fall in blood pressure, hypotension, that will trigger the sympathetic system. The baroreflex, there is activation of sympathetic system. Because of the activation, why sympathetic system gets activated? Because the sympathetic system, the brain thinks that there is hypotension, needs to be some correction for that, and because of that there is activation of sympathetic system, and with sympathetic system activation there is tachycardia, and this tachycardia is not direct tachycardia, and that is reflex tachycardia. Remember this difference very, very carefully. Okay, non-dihydropyridines produce direct bradycardia because of their direct action on the heart, whereas dihydropyridines, nifedipine and others, produce reflex tachycardia, and this reflex tachycardia is not because of cardiac action, but it is because of vascular action. In your entrance exams, if the question something like this, the adverse drug reactions of calcium channel blockers are all of the following except, and if out of the 4 options there is also bradycardia and there is also tachycardia, you should look at the question once again very carefully. Have they mentioned the type of calcium channel blocker? If they have not mentioned the type of calcium channel blocker, remember that a calcium channel blocker can produce both tachycardia and bradycardia as an adverse drug reaction. It all depends on the type of calcium channel blocker. If it is a dihydropyridine, more often there will be tachycardia, and it is reflex tachycardia. If it is a non-dihydropyridine, there will be bradycardia, and it is direct bradycardia. This is very, very important, and this important concept also leads to the next difference. See here, we established that we should not combine verapamil diltiazem with beta blockers, because there is going to be additional or even supraadditional myocardial depression. But what about dihydropyridines? Dihydropyridines produce tachycardia, reflex tachycardia, but more often we do not want that. That is the reason why we often combine dihydropyridines with the beta blockers. And frequently we see this combination, atenolol plus amlodipine. What is this combination going to do? Amlodipine is going to produce reflex tachycardia as an ADR, and the beta blocker, which is atenolol, that is going to overcome the reflex tachycardia that is produced by the amlodipine. So this combination is very, very popular, atenolol with amlodipine. Remember this very important difference. Beta blockers should be combined with dihydropyridines. Beta blockers should not be combined with verapamil diltiazem. This difference is very important. Now there are other DHP like side effects that are because of vasodilation. They will produce especially short acting DHPs will produce paradoxical worsening of ischemia. The reason for that is because of their interference with the coronary autoregulation, leading to coronary steal phenomenon. Next, there is ankle edema. This is a very frequently observed ADR that is seen with the DHPs. Why this ankle edema is seen? Remember, DHPs are vasodilators. They dilate both large arteries and smaller arterioles. So there is arteriodilatation, but at the same time there is also hypotension. This hypotension is also has activated the sympathetic nervous system. Sympathetic nervous system leads to vasoconstriction. Now, arterioles, there is vasodilatation because of the DHP, and the venules, there is vasoconstriction because of the sympathetic nervous system, sympathetic system activation. So arterioles are dilated, venules are constricted. What is going to happen? Especially in the periphery, especially in ankles, what is going to happen? The plasma is going to exude out of the dilated arteries, arterioles. It cannot enter back into the venules because venules are constricted. So all the plasma, all the fluid starts accumulating in the dependent regions. That is the reason why there is ankle edema. Ankle edema is very frequently seen with dihydropyridine calcium channel blockers. It's a very frequent ADR. So all these are the cardiovascular ADRs. The extravascular ADR, extra cardiac ADRs can be grouped as ADRs due to smooth muscle relaxation. So these smooth muscle, non-vascular smooth muscle. So GI wall smooth muscle relaxation. What is going to happen if there is relaxation of the GI wall smooth muscle? There is going to be reduced GI motility leading to constipation. Constipation again is a very frequent ADR that is seen with dihydropyridines. Now relaxation of lower esophageal sphincter, that will lead to worsening of gastroesophageal reflux. Bladder relaxation, bladder wall smooth muscle relaxation, that will lead to voiding difficulties. And finally uterine smooth muscle relaxation, that can delay the onset and progression of labor. This is an ADR. This is also a use. Nifedipine is a frequently used tocolytic agent, especially in preterm pregnancy. If the patient is going to premature labor, you give a calcium channel blocker such as nifedipine. What is it going to do? It is going to relax the uterine wall smooth muscle, and this will delay the onset and progression of labor. The same effect can be an adverse effect, can be a beneficial effect. And there are certain other ADRs. It can theoretically lead to decrease in insulin release. It can worsen the diabetes, and it is the dihydropyridines are one of the common causes for gingival hyperplasia. Now we have finished the ADRs. Only one heading is remaining, and that is the uses. You can again classify the uses of calcium channel blockers into cardiac uses and extra cardiac uses. Extra cardiac uses are very few, unlike beta blockers, which are having lot of cardiac uses, lot of extra cardiac uses. Calcium channel blockers are having more of cardiac uses than extra cardiac uses. So first cardiac use, we are discussing about calcium channel blockers as anti-anginal agents. That is the first use. The angina, chronic prophylaxis of angina, and I told you in the beginning itself, calcium channel blockers can be used for the chronic prophylaxis of all the three types of angina: stable angina, unstable angina, variant angina. However, stable angina is the place where we use dihydropyridines more often. And in stable angina, we combine dihydropyridines with beta blockers. We can also use verapamil diltiazem, but frequently we use dihydropyridines. Unstable angina, dihydropyridines have more of adjuvant role. Finally, variant angina, also we can use dihydropyridines. The mechanism of action is different there. That is about angina. Second cardiovascular use is for the secondary prophylaxis of myocardial infarction. And the rationale is similar to why we use beta blockers in the secondary prophylaxis of myocardial infarction. What is the rationale? It will reduce the myocardial work because of both cardiac depression and because of peripheral vasodilatation, peripheral reduction in the arterial blood pressure. Because of both of these conditions, cardiac work is reduced. So that will provide rest to the heart. So that is the rationale. So we use calcium channel blockers whenever we cannot use beta blockers. For example, the patient is also having a bronchial asthma or some other contraindication for beta blockers. We cannot use beta blockers, but we have to somehow produce myocardial depression in a controlled way. In that case, we use calcium channel blockers. And we use verapamil diltiazem more often than dihydropyridines because the ultimate thing that we need here is cardiac depression. So we use verapamil diltiazem more often than dihydropyridines. We should avoid this during evolving myocardial infarction because already the heart is undergoing depression. here we should not give a drug which will worsen the myocardial depression. Next, arrhythmias, supraventricular tachyarrhythmias. So which drug we should use here? We should use dihydropyridines or non-dihydropyridines. It is a cardiac indication, so we should use non-dihydropyridines, especially verapamil and PSVT, paroxysmal supraventricular tachycardia. The drug of choice for that is verapamil, or we can also use adenosine. And we are having other supraventricular tachyarrhythmias, atrial flutter fibrillation, we can use verapamil, or we can also use diltiazem. And there are certain other indications, perhaps the most frequently used indication wherein the calcium channel blockers are used is the hypertension. And for hypertension we use dihydropyridines, especially drugs like amlodipine. We also use non-dihydropyridines, but DHPs are preferred. And peripheral vascular diseases such as Raynaud's, again the rationale is the same there. Raynaud's, there is peripheral arterioconstriction. We use these drugs, they will produce arteriodilatation, and for the same reason we use dihydropyridines more than non-dihydropyridines. And hypertrophic obstructive cardiomyopathy, we use verapamil there because of the same rationale as why we use for secondary prophylaxis of myocardial infarction. Verapamil produces cardiac depression that will lead to reduced cardiac work. So by this time I hope you know why we should classify the calcium channel blockers into dihydropyridines and non-dihydropyridines. Every step, every heading, these two drugs differ. Apart from mechanism of action, every step these two drugs are different. Action, okay, ADRs, uses, every step these two drugs are different. We have certain extra cardiac uses for these drugs. One I have already told you, tocolytic. We use nifedipine as a tocolytic, especially in preterm pregnancy. And nocturnal leg cramps, we can use verapamil. There are other better drugs also for that. And verapamil has an additional action. It will inhibit something called as PGP. P stands for permeability and GP stands for glycoprotein, permeability glycoprotein. This permeability glycoprotein has been found to be responsible for excluding or kicking out the drugs from within the malarial parasite and from within the cancerous drugs. Somehow these drugs are able to enter the malarial parasite or the cancerous drugs. What malarial parasite and cancerous drugs, cancerous cells, what they will do, they will develop this P glycoprotein. What this P glycoprotein will do, it will simply extrude the drug that has entered inside the cell. That will lead to resistance. Verapamil has been found to inhibit this P glycoprotein. So verapamil has been found to be useful to minimize the drug resistance that is seen with anti-malarial drugs and anti-cancer drugs. This is another use. You can write it to gain extra marks. So we have finished describing calcium channel blockers under most of these headings. I have purposefully skipped the pharmacokinetic highlights and I have purposefully skipped some of the other headings. You can observe, you can read that in your textbook. So I hope I have been able to simplify this topic for you. Any doubts you are having, please feel free to ask them in the comment section. Thank you. Namaste. Have a nice day.